As neurosurgeons, we deal most often with intracranial hypertension, that is high intracranial pressure. And this topic is something different from what we routinely practice. And it is important to know for surgeons this topic because sometimes this condition can present with CT scan findings, which can look like high intracranial pressure, but actually the patient may be having low intracranial pressure. Spontaneous intracranial hypotension is a debilitating postural headache syndrome, which is secondary to spontaneous spinal CSF leak or hypotension in the CSF. It was described by German neurologist in 1938 as hypolicuria, that means low CSF volume inside the cranial cavity. And it is relatively rare condition as compared to other conditions which cause raised intracranial pressure and is more often seen in women than men. And this condition is often misdiagnosed and underdiagnosed because many people are not familiar with this condition, including neurologists and neurosurgeons. Sometimes it is diagnosed as postural orthostatic tachycardia syndrome or orthostatic hypotension, cervicogenic migraine or vestibular migraine. And sometimes patients are even labeled hysterical because of symptoms due to hypotension, which are sometimes quite weird. The International Classification of Headache Disorders, third edition, described the diagnostic criteria for SIH. So, which says that headache should develop in relationship to the low CSF pressure or leak, or it should lead to discovery of CSF leak. And if you do lumbar puncture, then CSF pressure should be less than 60 millimeter of CSF. And on neuroimaging, there should be evidence of leak. And there should not be any other cause of headache according to ICHT-3 diagnosis. However, Schwinneck described hypotension as a demonstration of leak and cranial imaging finding consistent with the spontaneous intracranial hypotension with or without documented low pressure on lumbar CSF findings. So the headache is classically described as orthostatic, that is when the patient gets up from the supine position. So within 15 minutes, patient starts complaining of headache, and it is usually in the occipital regions. However, it can be in frontal or even diffuse. And in 8% of the cases, the headache may not be orthostatic. The patient may get headache even while lying down. And in about 10% cases, the headache can be thunderclap headache similar to spontaneous subarachnoid hemorrhage or due to intracranial arterial dissections. And some patients do not have headache, they may have some other symptoms, and these are the patients who are often misdiagnosed. And it is not surprising that patients may present with history of tribal trauma like sports injury or fall from their own height, or after a coughing or straining and sneezing, the headache starts. The other common symptoms associated with headache are nausea and vomiting, seen in nearly half of the patients, and neck pain and neck stiffness. So these two symptoms often confused with cervicogenic headache. And tinnitus, dizziness, and hearing disturbance can also be seen due to low intracranial pressure. The rare symptoms are like visual disturbance, vertigo, cognitive symptoms, multiple cranial palsy, cerebral venous thrombosis, quadriplegia, cerebellar hemorrhage, movement disorder, status epilepticus, spine disease, and coma have also been reported due to sudden intracranial hypotension. Though lumbar puncture may indicate that the pressure is low, it is not a good test. It is just a snapshot method of measurement. Though it has got good sensitivity, but it is still not excellent, and it can support the diagnosis of SIH but not required for diagnosis of SIH, as 1/3 of the patients may have normal pressure. And the CSF examination is done in fetal position with curled up and compressed abdomen. So at that time pressure can be normal and even paradoxically abnormally high if the patient is obese. And it does not reflect the intracranial pressure in the upright position, and patient is symptomatic in upright position, not in the lateral decrepitous position. And it does not offer any information regarding CSF dynamics with postural change. The lumbar puncture, though it's sensitive, it's not required for diagnosis of SIH. Now, if you remember intracranial pressure Monro-Kelly doctrine, the same pathophysiology applies for hypotension as well. So the normal intracranial volume is largely comprised of brain and about 10 to 15% blood and less than 10% CSF. So what happens in intracranial hypotension? The CSF leaks from the spinal canal. So the CSF volume inside the cranial cavity decreases. To compensate for reduction of the CSF volume, brain cannot increase in the size. So what happens? The blood in the intracranial cavity increases. As compared to normal, you see the proportion of blood is less, but in patient with hypotension, blood increases. This increased blood in the intracranial cavity is responsible for most of the imaging findings. So if the CSF is lost gradually, compensation usually occurs by increasing cerebral blood volume, and it is largely venous blood, which is reflected by engorged venous sinuses and engorged veins. But if CSF is lost rapidly, there is the brain tissue displacement and damage, which is which results in tearing of the bridging veins or bleeding from already engorged vein, resulting in acute subdural hematomas. So the commonest finding in spontaneous intracranial hypotension is pachymeningeal thickening. So if you do just a plain T2 weighted images, you may not find anything abnormal. However, in FLAR, you can see small subdural collection. It's small subdural collection or pachymeningeal thickening. Actually, it is not a subdural collection. It is a pachymeningeal thickening, that is thickened dura. In presence of contrast imaging, this thickened dura enhances and it is clearly visible. And the venous sinuses like this, both transverse sinuses become engorged. Superior sagittal sinus also engorges, and occipital sinus also becomes thick. And in T2 weighted, you can see even subdural collection, and you can see the big sinuses even in plain T2 weighted image, like the black dot of superior sagittal sinus becomes like quite big. The other finding is pituitary enlargement. Normally, pituitary is concave on top, but in cases of intracranial hypotension, pituitary becomes thick and it becomes convex in shape. The subdural hematomas, depending on the amount of CSF leak and the duration of CSF leak, it can be chronic, subacute, or even acute. There is a distance between mammillary bodies and pons. So what happens due to sagging of the brain, hind brain, and entire brain, the distance between mammillary body and pons decreases. Normal distance is 6.5 millimeters. So in this case, you can see the mammillary bodies are pointing towards the pons, which indicate that the distance between mammillary body and pons has decreased. Here you can also see the enlargement of pituitary gland. The spine imaging is required to demonstrate CSF leak. Sometimes you may be able to demonstrate CSF leak, sometimes you are not able to demonstrate CSF leak. As the veins increase in the size in intracranial cavity, similarly venous engorgement can be seen in spinal canal, which can give false impression of spinal dural AV fistula. You can see the black spots here, which indicate the engorged vein. Like in the axial section also, the epidural veins look thick. But more important is presence of CSF in the epidural space, which is not very clearly demonstrable on the sagittal imaging, but in the X-ray imaging you can see this is grayish spinal cord. This black line is dura, and there is hardly any CSF between black line dura and the spinal cord. But outside this black line, between the lamina and this black line, that is dural line, you can see the hyperintensity, which indicates CSF in the epidural space, which is leaked from the subarachnoid space. So if you are not able to demonstrate leakage, one can do spinal imaging with intrathecal gadolinium injection. So this is T1 weighted imaging with intrathecal gadolinium injection, which is showing leakage of the CSF at the C1 C2 region. You can see here there is a rent and the leakage of the CSF. Here you can see the dura nicely. You can see the dura, but there is a rent in the dura, and CSF is leaking out at the C1 level. So the commonest finding are diffuse pachymeningeal enhancement, which is the commonest finding, followed by venous engorgement and brain sagging, like you'll see tonsillar herniation, decreased mammillothalamic interval, sagging of the splenium of the corpus callosum and midbrain. And other is enlarged pituitary gland. Subdural collections may be seen, and and sometimes the imaging findings are normal in the brain. So depending on the imaging findings, there is something called SIH score. So 2 points are given for major findings like pachymeningeal enhancement, engorgement of venous sinuses, and effacement of suprasellar cisterns. And minor findings, only 1 point are given like subdural fluid collection, effacement of prepontine cistern, and decreased mammillothalamic distance. So total points are 9. If the points are 6 to 9, it definitely indicates diagnosis of SIH, whereas less points may indicate probability of SIH when additional imaging may be required. So other spine may be present. So uncommon findings are also seen in some SIH, like sometimes due to stretching of the veins and engorgement of the venous sinuses, there can be stagnation resulting in venous thrombosis. So this is a case of superior sagittal venous thrombosis. Like one may believe the superior sagittal venous thrombosis causes raised intracranial pressure, but this is a consequence of low intracranial pressure. And this can even affect the cerebral perfusion. So frontotemporal dementia has also been reported as a presentation of SIH. So this is the metabolic imaging showing reduced uptake in the frontal and temporal region due to intracranial hypotension, which causes reduced perfusion and patient presents with dementia rather than headache. Sometimes the CSF can leak and directly communicate with the epidural vein, resulting in CSF venous fistula. You can see the leakage of the CSF, which is directly communicating to one of the epidural veins, leading to CSF venous fistula. So, if the clinical suspicion is high, you may have to do one or the other imaging till you find the cause of CSF leak so that you can decide the treatment. So 28% of the patients, they successfully respond to conservative measures and don't require any invasive treatment. The best conservative measure is absolute bed rest. Avoid upright position and ask the patient to lie most of the time in the bed except for attending nature's call. Besides that, drinking plenty of coffee and salts added to water and lot of fluids and paracetamol will relieve symptoms in 28% of the patients within 1 week, and you may not require any additional measures. So these are the patients who have very small tear in the dura, which heals on bed rest as there is no CSF gradient and leak stops on its own. When a patient does not respond to the simple measures, epidural blood patch is required. So usually after 1 week of medical management, if patient still has symptoms, then epidural blood patch may be given. However, early epidural blood patch should be given if there is a documented CSF leak. There is no point in waiting for conservative management. Or if patient presents with rapidly deteriorating neurological symptoms such as coma or drowsiness, then one should not wait for conservative management, and if SIH is suspected, then epidural blood patch should be given. The exact mechanism by which epidural blood patch helps is not known, but it results in formation of the plug at the site of the dural defect. And sometimes large volume blood patch increases the epidural pressure, thereby decreasing the subarachnoid pressure and relieving the symptoms. So large volume blood patch is required if it is given at lumbar level, that is also called as non-targeted epidural blood. And at thoracic level, less amount, that is only 10 to 20 ml is sufficient, whereas in cervical level, 4 to 6 ml is more than enough to seal the defect. Single epidural blood patch is effective in 2/3 of the patient, and with 2 or 3 times, 90% of the patients will have cure. One should wait for 2 to 3 days before deciding whether next epidural blood patch is required or not. However, failures are higher if the site of CSF leak is not visualized, or when blood patches are performed at lumbar region rather than targeted region. Though there is not much difference between targeted and non-targeted blood patch, but if you are able to demonstrate CSF leak, it is better to perform targeted blood patch. The complications are due to accidental subarachnoid puncture. Hence, one should do contrast study and document that needle is in the epidural space before giving the blood. Because if dura is punctured, further CSF leak will occur, which will result in further hypotension and exaggeration of symptoms. And complications are more likely if the epidural blood patch is performed at cervical or thoracic level. Surgical management is indicated when non-surgical measures like epidural blood patch has failed, or where there are bony abnormalities like bony spicules and at the site of the dural defect, then surgery is required, as this will not respond to epidural blood patch. And if there is a clear-cut meningeal diverticulum, which will definitely not respond to epidural blood patch, and surgical excision of this diverticula is required. And when there is a cerebrovenous fistula, that is the CSF is draining directly into the vein, then ligation of that vein and the fistula is required. And if the defect is large, the epidural blood patch will not take care, and surgery is required. So depending on the site of the leak, like if it is a ventral leak, which is also called type 1 defect, which is due to bony spicule or osteophyte anteriorly, transdural approach, like open the dura, cut denticulate ligament, gently mobilize the spinal cord, identify the defect and seal the defect with either dural substitute or fat or fascia supplemented with fibrin glue. When the defect is lateral, like meningeal diverticulum, then extradural posterior approach is required, no need to open dura. And when the dura defect is at the foramen, then foraminotomy and excision of the fistula and repair of the dura defect is required. So this is a case of surgical management. You can see there is a large dural defect. So this will not respond to the medical management or due to epidural patch. So in this case, it is better to do surgery early and do the repair. So this is a follow-up imaging after repair in one of our case. You can see there was a tonsillar herniation which has ascended up, and there is no more CSF leak. Now comes the dilemma of management of subdural hematoma in patients with spontaneous intracranial hypotension. So subdural hematoma can also present with headache, and spontaneous intracranial hypotension can also present with headache. Subdural hematoma can also present with deterioration in sensorium, and intracranial hypotension can also present with deterioration in sensorium. So there is a dilemma whether to treat subdural first or intracranial hypotension first. So unless there is a life-threatening subdural hematoma causing midline shift and patient presenting in coma, it should not be treated, and epidural blood patch should be given first, particularly in case of subacute or chronic subdural hematomas. And if the patient has only headache or minimal alteration in sensory, even if patient is drowsy like GCS 13, 12 or something like that, epidural blood patch should be the first treatment. Whereas if the midline shift is present and patient is in poor GCS with pupil dilatation or something, then craniotomy and evacuation of the subdural hematoma is required. So this is the algorithm for management of spontaneous intracranial hypotension. So first, a brain MRI should be done with and without contrast, and diagnosis should be established. And if you are not able to demonstrate CSF leak, just large volume non-targeted blood patch should be given. And if response is sustained for more than 3 months, nothing further is required. But if there is recurrence or no response, then spine MRI should be done with myelogram, with or without myelogram. And if there is a fluid present, Then dynamic study with digital subtraction and myelogram should be done. And if there is no epidural fluid present, then rule out with lumbar puncture in CT myelogram. And if there are suspicious finding, then targeted blood patch at the site of leak should be given. And if there is response, then good. But if there is no response, then second level targeted blood patch can be considered. And if there is no response, then surgery must be considered if there is a large defect. And if no further response, then no further treatment should be given. And other causes of headache should be found out. And if there is recurrence after 3 months, then same cycle should be repeated. So what are the signs of successful treatment of epidural blood patch? Like this is one of our cases. Like you can see the splenium is sagging down. So after epidural blood patch successful treatment, the splenium comes to the normal position. There was a venous engorgement. You can see in the sinus is looking very thick. Now sinus is just appearing as a single line. There was a tonsillar herniation before. You can see that elongated shape of tonsil. Now the tonsil is a rounded shape and it has gone up. The pituitary is appearing convex on the upper surface. It has become normal. Now it is concave. You can see the distance between mammillary body and pons was reduced. There is no CSF seen. Now the distance has become normal. So these are the signs of successful treatment of SIH. So I will end with a case illustration which will give you an insight how SIH is misdiagnosed and how it should be appropriately diagnosed and treated. So this is a case of 44-year-old man who came from Jharkhand to Bangalore, and he came with a history of brick falling on his head in February. So you can see from your screen, you will see that CT scan looks largely normal. There is no blood clot or anything. But on changing the window, you may be able to see there may be thin bilateral subdural hematoma. Now the brick just fell down. Patient did not have loss of consciousness. It was not a great trauma to cause bilateral subdural hematomas. But the patient has bilateral subdural. At the time, suspicion should have been made that injury was not severe. Then why patient should have subdural hematoma? So in April, he started having headaches, which was holocranial as well as occipital. And repeat imaging showed now subacute to chronic subdural hematoma. You can see the brain appears like full. It is because of sagging. So again, no treatment was offered in Jharkhand as the subdural hematoma was thin, and he was given analgesics. In June, the headache became worse. It started becoming daily, and it was like a chronic daily disabling headache. Now, repeat imaging showed increase in the size of subdural collection with acute chronic appearance. And now patients started complaining of giddiness, imbalance while walking, diplopia. Hence, burhole and evacuation of subdural was done in Jharkhand in June. In spite of burhole and evacuation, headache persisted, and at this time he came to us. So you can see the burholes and subdural effusions are still present. So we raised the suspicion of intracranial hypotension. And contrast imaging of brain was performed, which showed all classical features like enlarged pituitary gland, the thickened epidural spaces, enlarged sinuses, and some tonsillar herniation. So this all were the signs of intracranial hypotension. You can see even the splenium is sagging and touching the wounds. So spinal imaging was done, which shows epidural CSF collection. You can see the black line of the dura in the dorsal epidural space, and there is a white collection outside the dura, which indicates epidural CSF leak. And at this point, there is some bone is spicule. So probably that was the site of leak. So the patient underwent epiduroscopy, that is injection of the contrast material at the cervicothoracic region, and it was confirmed that needle was in the epidural space. Once it was confirmed that needle was in epidural space, autologous blood was taken and it was injected in the epidural space. Here you can see the blood being injected in the epidural space. It is injected very slowly, like 1 to 2 ml per minute. So after injection treatment, we did a CT scan and demonstrated that the contrast in the blood was in the epidural space, not in the subdural space. You can see the epidural air as well and air in the soft tissue. So this confirmed that we injected the blood successfully in the epidural space. So take home messages for the evaluation of headache, MRI should be done with contrast, MR venogram should be done, and MRI of spine should be done to look for CSF leak. So old paradigm was like, as a neurosurgeon you do bilateral subdural, and you used to think whether this is causing patient symptoms or not, and if you are in doubt you just take out the subdurals. No, but in new paradigm, when you see bilateral subdural without history of trauma in a young patient or with minimum or very trivial trauma, which you know it cannot cause subdural hematoma in young patient, so look for the site of CSF leak, suspect intracranial hypotension, and when in doubt, seal it off. Thank you. So you can see whatever I have presented in one of our articles on spontaneous intracranial hypotension, which was published in Neurology India last year.